Good morning. Myself, Dr. Naga Supraja from the Department of Pediatric and Preventive Dentistry. The topic of presentation today is indirect pulp capping. These are the contents under which the topic is being discussed. Coming to the introduction, pulp is a soft inner structure of the teeth containing the nerve and the blood vessel. It is also called as the tooth pulp. The pulp occupies the center of each tooth and shape itself to the maturation of the teeth. Treatment of the pulpally involved primary teeth is the most challenging. The pulp treatment modality includes conservative treatment and the radical treatment. Under the conservative treatment, it includes application of protective base, indirect pulp capping, direct pulp capping, pulpotomy, apexogenesis and regeneration. Under the radical treatment, it includes pulpectomy, apexification and the root canal treatment. In the vital pulp therapy, it is mainly designed to preserve and maintain the vitality of the primary teeth, which has been exposed due to the trauma or caries or restorative procedures or anatomic anomalies. It involves removal of the local irritant and placement of protective material directly or indirectly over the pulp. According to AAPD, teeth exhibiting provoked pain of short duration that is relieved upon the removal of stimulus with analgesics or by brushing without signs and symptoms of irreversible pulpitis is called the vital pulp therapy. The main objectives of vital pulp therapy is to maintain the integrity and health of the teeth and their supporting structures and induce a physical protective barrier over the pulp to maintain the vitality of the teeth and to initiate the formation of tertiary or reparative dentin. The clinician should carefully assess all the following information. It includes medical history, clinical evaluation, vitality testing, periodontal probing, mobility assessment, radiographs or presence of any localized swelling. Coming to the outcome of the vital pulp therapy, it depends mainly on the age of the patient and extent of bacterial contamination, degree of pulpal inflammation, choice of pulp capping material and quality of the permanent restoration. Pulp capping. To maintain the pulp vitality by placing the suitable dressing either directly or indirectly or a thin layer of residual layer of slightly softened dentin. It mainly involves two types based on the remaining dentin thickness, that is indirect pulp capping. That it means with a 2 to 0.02 mm and direct pulp capping is 0 to 0.25 mm. In the prepared cavity, if the remaining dentin thickness is more than 0.5 mm, it is ideal for avoiding the pulpal inflammation. The reactionary dentin forms when remaining dentin thickness is 2.5 to 0.01 mm, whereas reparative dentin is formed following the pulpal exposure. Coming to the indirect pulp capping, these are the definitions which are given by the different societies. According to AAPD, it is a procedure in which the non-remineralizable carious tissue is removed and a thin layer of caries is left at the deepest sites of cavity preparation, where the complete caries removal would result in pulpal exposure. And according to Engel, it is a procedure where a small amount of carious dentin is retained in deep areas of the cavity to avoid the exposure of the pulp, followed by placement of suitable medicament and the restorative material that seals off the carious dentin and encourages the pulp recovery. According to McDonald, it involves only the gross removal of the carious tissue and the cavity is sealed for time with a biocompatible material. According to Grossman, it is a procedure where the deepest layer of remaining affected carious dentin is covered with layer of biocompatible material in order to prevent the pulpal exposure and further trauma to the pulp. According to the Cohen, it is a technique for avoiding the pulpal exposure in the treatment of the teeth with deep carious lesions in which there exists no clinical evidence of pulpal degeneration or periapical disease. Coming to the history, the IPC was advocated more than 200 years ago. Rip has reported that Fauchard in the year 1746 has advocated a conservative treatment of extensively carious teeth, that is retention of some caries, because if the caries was completely removed, the pulpal exposure can occur. Hence the term indirect pulp capping was recently replaced by the term indirect pulp treatment. Rationale: to encourage the formation of the reactionary layer of dentin with preservation of pulp pulpal health and vitality, and removal of the deep carious lesion and restoration of the crown after the placement of an appropriate material. Aims and objectives. It includes arresting the carious process, causes activation of reparative mechanism to lay additional dentin and avoid the pulpal exposure. Dentin to remineralize by stimulating the underlying odontoblasts to form the tertiary dentin. Removal of infected dentin and disinfection of residual affected dentin, promoting the dentinal sclerosis. Remineralization of the carious dentin. These are the differences between infected dentin and affected dentin. In the infected dentin is highly demineralized, unremineralizable, and it involves only the superficial layer. It lacks sensation, stained by 0.5% fustian, and should be excavated. Whereas in the affected dentin, it is intermediately demineralized. There will be remineralizable collagen. It involves the deeper layer. It is most sensitive part of the tooth. It does not stain and should be left to remineralize. Indications include the teeth diagnosed with normal pulp with no signs and symptoms of pulpitis. When pulpal inflammation is judged to be minimal, and complete removal of caries would cause pulpal exposure. Contraindications are large pulp exposure, non-restorable tooth or tooth with low prognosis, any signs of pulpal or periapical pathology, or soft leathery dentin covering a very large area of the cavity. Basic principle of IPC is, it is based on the theory that the zone of affected demineralized dentin exists between the outer infected layer of the dentin and also the pulp. When the infected dentin is removed, the affected dentin can remineralize and the odontoblasts form the reparative dentin. Thus, we can prevent the pulpal exposure. After the clinical examination and history, and based on the radiographic examination, we come to the diagnosis whether we can go for the conservative treatment or the radicular treatment. Uses of indirect pulp treatment has been questioned because the reasons include response to caries and resultant pulpal inflammation is faster, and in the permanent teeth there will be 0.06 mm pulpal inflammation, and all caries must be removed if pulpal exposure has occurred. It includes the direct pulp capping or pulpotomy treatment. Success of indirect pulp capping depends on the tooth location and based on the restorative material, and also on the basis of use of base. Overall success rate of indirect pulp capping in primary posterior teeth was about 95%, and the clinical procedure, it can be done in a single step or two-step approach. The main objective is that to arrest the caries lesion progression and allow formation of the reparative dentin. Stepwise excavation procedure is recommended due to it avoids the unintentional pulpal exposure which may deteriorate the pulp prognosis, and the dentist get a chance to assess the reaction of the tooth as well as gain information of the changes in the caries activity. It gives an opportunity to remove the slow progressing lesion in slightly infected, discolored, demineralized dentin before the placement of final restoration. The final excavation of caries is safer in the second sitting as it is easier to remove the dry carious dentin. In the first appointment, the procedure involves, after the administration of local anesthesia, isolate the teeth with rubber dam and then prepare the outline cavity and remove the infected dentin with the help of the caries detector dye, and stop excavation after firm resistance of sound dentin is felt, and the cavity is flushed with saline and dried with a cotton pellet, and the area is covered with calcium hydroxide, and on that the ZOE is placed. The cavity is then not disturbed for about 6 to 8 weeks. Between the appointment, the history must be negative and temporary restoration should be intact. If the reparative dentin is formed, the permanent restoration followed by full coverage restoration is chosen. But if caries remains on re-entry in the second appointment, remove the caries. Previous remaining carious dentin will have become dried out, flaky, and it can be easily removed. The area around the potential exposure will appear whitish, maybe soft, which is pre-dentin. That time we should not disturb that area, and the cavity is flushed out and dried gently. Cover the floor with calcium hydroxide and the base is built with reinforced zinc oxide eugenol or the glass enamel cement, and the final restoration is placed over it. This is a picture showing that in this the caries is removed and only the infected dentin is also removed, and we need to wait for 6 to 8 weeks for the reparative dentin to form. And after 6 to 8 weeks, if the reparative dentin has formed, then the permanent restoration can be placed. In the single appointment technique, after administration of LA, the tooth is isolated with rubber dam and the cavity outline is formed. All the margins are left adequately supported and peripheral caries is removed with large round burr, and the dentino-enamel junction must be free from all softened material and stain even if the stain is firm. Remove all the soft moisture and leathery texture of dentin. A protective radio-opaque biocompatible base material must be placed prior to the temporary restoration. Assure retention and sealing of the temporary restoration. The removal of bacteria and substrate together with an effective seal of restoration provides the means whereby the pulp can recover the laying down secondary dentin. If the tooth remains asymptomatic, then there is no need for the re-entry again. This is a picture showing, in the first picture, remove the caries with a slow speed burr, and in the second picture we can clearly see that A represents the necrotic tissue and the second layer is the leathery and the third layer is 1 mm to remain. In the third picture, calcium hydroxide is placed over it, and in the fourth picture, upon the calcium hydroxide there is placement of the zinc oxide eugenol above it. Advantages of two appointment techniques include avoid unintentional pulpal exposure, dentist get chance to assess the reaction of the tooth and caries activity, it helps to remove slowly progressing lesion, final excavation of caries is safer in the second sitting. Coming to the features, in the one appointment, difficulty with the procedure is to determine at what point excavation is halted. Voids under the restorative material result during the remineralization process, in which the carious dentin is dried out and loses the volume. The restoration failure and rapid reactivation of the dormant lesion. It is not recommended as the predictable treatment for the permanent teeth, whereas for the two appointment technique, it includes unintended pulpal exposure, worsen the prognosis, clinically assessed the reaction of the teeth and progress of dentin bridge formation. The final excavation of caries is safer in the second appointment when sufficient formation of dentin has taken place, as it involves the removal of only the dried out dentin. Controversies of single versus two visit indirect pulp capping. In the two visit indirect pulp capping, there is increased risk of pulpal exposure at re-entry, and also it includes more cost. Studies has shown that the success rate of single visit indirect pulp capping with calcium hydroxide was about 73 to 98%. And Luang et al. And Furban has suggested that there is decrease in bacteria in deep carious lesion after placement of calcium hydroxide or modified zinc oxide eugenol. No re-entry as final restorations remain sealed and the tooth becomes asymptomatic. All the carious dentin can be removed except expose the pulp, no need of re-entry. More carious dentin left, re-entry is necessary. Evolving issues of indirect pulp capping. According to DCNA, imminent exposure soft infected dentin was left and a non-hardening material such as calcium hydroxide is used, then we need to re-enter the cavity, and a shift away from the re-entry has occurred in the year 1997 and 2005. One appointment is highly successful. Shift the base, that is from zinc oxide eugenol and calcium hydroxide to the glass enamel cement according to the pediatric dentistry. Controversies exist regarding the basing materials. One group of thought is that the calcium hydroxide must be in direct contact with the pulpal tissue to form the reparative dentin, and another group says that calcium hydroxide is soluble and hence is transmitted by the fluid in the dentinal tubules to the pulp and to form the reparative dentin. Evaluation of therapy. After period of 13 to 21 months, lining medicaments such as Dical is highly effective, and irritational dentin in 40 of 41 young molars with by using the zinc oxide eugenol, the pulp becomes normal or mildly inflamed in 34 to 630 days due to the carious decalcified dentin and rhythmic layers of irregular reparative dentin and regular tubular dentin and normal pulp. There will be slight to moderate inflammation as zinc oxide eugenol is used in unlined cavities of less than 0.5 ml, and carious dentin wiped with 10% solution of stannous fluoride for 5 minutes and zinc oxide eugenol, and it can be remineralized. Factors determining the success of indirect pulp capping, it includes the remaining dentin thickness of about 0.5 to 2 mm and the choice of restorative material which is used in the indirect pulp capping. Coming to ideal requirements of pulp capping materials according to the Cohen, it should be biocompatible, bactericidal or bacteriostatic. It should promote healing. It should not harm the pulp, surrounding structures and the permanent tooth germ. It should maintain the pulp vitality, not interfere with the physiologic process of resorption. It should provide the bacterial seal, and it should be radio opaque, and it should resist the forces, and it should adhere to the dentin and reparative dentin formation. These are some of the materials which are used as the pulp capping agents. For example, like calcium hydroxide, zinc oxide eugenol, cement, corticosteroids, antibiotics, polycarboxylate cement, terracal cement, castor oil bean cement, endosequence root repair material, isobutyl cyanoacrylate and tricalcium phosphate ceramic, collagen bonding agents, calcium phosphate, hydroxyapatite, mineral trioxide aggregate, biodentin, odontogenic amyloblast associated protein, growth factors, lasers and glass ionomer cement or the resin modified glass ionomer cement. The outcome, there is 3 distinctive types of new dentin formation taking place. In the first 30 days, there will be 1/5 of the tubular dentin formation. In the first 2 months, cellular fibrillar dentin is formed. In the 3rd month, the globular dentin is formed, and after more than 3 months, 0.1 mm of tubular dentin is formed. After the indirect placement of the restorative material in the pulp as a pulp capping agent, coming to the final restoration or the permanent restoration, it also plays a major role in the success of the indirect pulp capping, as it should completely seal the tooth, and the placement and the quality of permanent restoration can be crucial to the long-term maintenance of the pulp vitality and may be more significant than the actual pulp treatment. The main aim of the final restoration is to completely seal the tooth, and also sealing ability of the pulp capping material and effectively define the pulp from further microbial contamination. The incorporation of adhesive restorative materials as definitive final restorations minimizes tooth reduction, encourages the anatomic preservation, and thus provides better pulpal protection and repair potential. The post-operative follow-up and recall involves, after the treatment completion, the pulp status should be assessed periodically, such that we need to check whether there is maintenance of the pulpal vitality and normal function of the tooth and apical closure in the immature permanent teeth. The radiographic evaluation and the cold testing can most accurately assess the continued pulp health and are excellent predictors for measuring the survival rates. It is preferable to establish the recall rates individually based on the age of the patient, type of pulp capping material used, and the caries index, the patient need, periodontology and symptomatology of the tooth, and the periodontal status of the patient, and craniofacial development assessment in the younger patient. Hence, it is concluded that emphasis has been shifted from deemed organ concept of the exposed pulp to one of hope and recovery. The era of vital pulp therapy has been greatly enhanced with introduction of various pulp capping materials clarity on the biology of caries, comprehension of technological advances and conviction about the improved restorative materials has initiated a pulp preservation that indeed is a boon for the both clinician and also the patient. These are the references. Thank you.